Good afternoon, everybody. Today, our topic for discussion is imaging in surgery. Uh, I am not going to go into too much of detail about each of the modalities that we can use. This is to give you an overall idea about the techniques that we can use for imaging and the need for the imaging and the problems that you can have with some of these techniques. Yeah. First of all, obviously, you must know what are the indications for doing an imaging. The best imaging probably is done by our eyes, but the problem is the eyes cannot see inside the body. That is why we use imaging to look at things inside the body which cannot be seen by the naked eyes. So diagnosis. So I mean, probably the first indication for imaging would be diagnosis. You suspect a disease and you want to make sure that it is what you suspect. For example, you find a lump in the breast and you want to find out whether it is a malignancy or not. So you do a mammogram. A mammogram may not tell you 100% that this is a malignancy, but will give you a lot of details about the lump, which will point to whether it is a malignancy or not. Then you'll have to prove it by doing a tissue diagnosis. So like that, in each various parts of the body, you will use it for diagnosis. Or for, you suspect a fracture, you want to make sure whether there's a fracture or not. You take an X-ray, you'll know whether there's a fracture or not. So it helps in diagnosis, and it helps in localization of a disease. For example, if you again, if you have abdominal pain and you're suspecting intestinal obstruction, patient has intestinal obstruction, you want to know which part of the intestine is obstructed. Clinically, you may not be able to make out exactly where the obstruction is. So because the exact site is necessary to decide on the type of surgery that you want to do. In this situation, you can probably take a CT of the contrast CT of the abdomen, which will tell you exactly where the problem is. So that's how localization helps. Then, in cases of malignancy, we have to decide about the stage of the disease, because depending upon the stage of the disease, your treatment will vary. Sometimes in very advanced stages, you may not be able to give any curative treatment, but you can definitely give palliation. So that staging is important. Again, we'll take a carcinoma of the breast as an example. If you have a locally advanced carcinoma of the breast, you want to know whether it has become metastatic, because in a metastatic disease, all that you can do is give palliation. You cannot cure the disease, only palliation is necessary. So you won't unnecessarily do all sorts of surgeries and things like that. For that, you have to do staging. So you can do a CT or you can take a PET scan and all that, which will tell you whether the disease has spread to other parts of the body. That's what we mean by staging. The fourth indication for investigations would be when you want to take a biopsy. For example, you have a very small lesion which is not just palpable, and you want to take a FNAC from that. It is not possible always to do it without the help of image. So in that case, you can probably do an ultrasound guided FNAC, or even a CT guided FNAC, a mammogram, all that, which will help you to localize the lesion, and you will be able to guide your needle into the lesion. That's what we mean by a guided biopsy. Or if you have a lymph nodes in the abdomen, and you want to take a biopsy, you might have to do a laparotomy to get at the lymph node in the normal circumstances. But you can take a true cut biopsy using CT as a guide or an ultrasound as a guide. So guided biopsies are possible. And finally, you need imaging for following up a patient. Again, for example, when you have a carcinoma, say you have a patient with a carcinoma of the right breast, you've done an MRM on MRM, that is a modified radical mastectomy on that side, and the patient comes for follow-up. You want to see whether there is a carcinoma developing in the opposite breast, or whether there is a recurrence in the same on the same side. You will again resort to imaging, either MRI or depending upon the lot of factors. You will do some sort of imaging to see whether there is a recurrence. So these are some of the indications where you will use imaging in. Yeah, this is X-ray machine, which is one of the latest types of X-ray machines. X-rays were the first after eyes. Probably X-rays were the first imaging techniques that were used to diagnose disease. Yeah, this is a Röntgenogram that is discovered by Röntgen X-rays, isn't it? So X-ray of the abdomen. It's a plain X-ray. Yeah, I'll come to that later. What are X-rays? X-rays are ionizing radiation, isn't it? And they are absorbed by various tissues in various degrees. So air will let all the X-rays pass through it. That's and the on. So what you do is you have an X-ray film, just like the photographic films, something like the photographic films that we used to have in the olden days. Nowadays, with these digital photographs, you don't have those films. In fact, I think the films are not available nowadays. So these are some similar films, something like a photographic film, and then you put the patient between the X-ray tube and the film, and you switch on the machine. It produces a picture on the film. So the picture that is developed on the film will depend upon the tissues through which the X-ray is passing. So and this, the amount of absorption of, just like light, it will not pass through opaque objects, isn't it? It will only pass through transparent objects. So X-rays will also only pass through certain things. So that the tissue through which it will pass depends upon the density of the tissue and the atomic number of the tissue. And air on an X-ray looks black because all the X-ray passes through the air, whereas bone looks white. So that is the gradation from black to white. You can make out various different densities in the body depending upon this gradation of the X-ray that is passing through the thing. I told you air looks black, whereas metals will look white on an X-ray. In between, you get fat, soft tissue, bone, and mineral. So all these things you can make out air, whether there is air in the on the X-ray. So chest X-ray, if you take, you will find that the lungs contain air, so you get a black film. You will get in this black film, you will find bronchovascular markings produced by the bronchi and the blood vessels in the lung. Fat, again, you take an X-ray of the abdomen, under the skin and between the skin and the muscle, you might be able to see a comparatively radiolucent region which is produced by the fat, subcutaneous fat. Soft tissues, again, you can make out, you may not be able to make out too much of detail, but you can make out the difference between the bone, the skin, and the muscle. Bone, obviously, you can make out. I told you it looks white. So mineralization, supposing you have deposit of calcium somewhere else, like for example you have calcific pancreatitis, which is normally not seen in the pancreas. Calcium is not normal, but in a chronic calcific pancreatitis you can find these calculi. Or you have a renal calculus or a ureteric calculus, you can make out on an X-ray because it contains calcium which is radiopaque. So mineralization. Similarly, metals, foreign bodies, you can make out foreign bodies by taking a simple X-ray. Or yeah, so that is, these are the things that you can make out on a simple plain X-ray. Now, ionizing radiation has a lot of side deleterious effects. So, the thing to remember here is that normally there is a lot of background radiation that is there in the atmosphere, which we are not aware of, but it is always there. But this in itself is not harmful to the body unless you are exposed to, like for example, I don't know, you must have all heard about that Chernobyl disaster that took place in Russia, where an atomic reactor broke down and radiation came out of the containment zone. So people around it were exposed to radiation. There, what happens? The background radiation goes up, isn't it? Yeah, that is it. Another cause for radiation is medical exposure, and about 15% of radiation to the body, I mean, when you take the whole population, 15% is produced by medical radiation, medical exposure to radiation. Now, radiation exposure produces two types of reactions. One is dose dependent, like for example, repeated exposure to X-rays can give rise to cataracts in the eye, or it could be stochastic, that it is not dependent upon the dose, but certain tissues are sensitive to radiation, so they can undergo changes. Now, the changes that can take place due to the radiation could be, it can produce cancer, that is malignancies, various or it can, in the case of a fetus, it can produce fetal abnormalities, so congenital defects because of exposure to radiation. So that is why you have to be very careful when you use X-rays on people. Yeah, this is to show you the risk of cancer on various X-rays. That is, if you take a chest X-ray, it is a 1 in 10 million, whereas if you take an abdomen and pelvis, it is 1 in 1000, because the amount of radiation is much more in an X-ray of the abdomen and pelvis compared to an X-ray of the chest or the limbs. So the dosage of radiation varies depending upon the area that you are X-raying, because penetration varies depending upon the thickness and all sorts of things. So the dosage will vary depending. So that is why you have these different risk for cancer. This is a statement which is probably something we won't like to hear. What it states is that 30% of CTs that are taken are unnecessary. So when we order a CT or any investigation for that matter, we must follow the guidelines for which you must be very sure about the indication for the investigation. CTs, especially because it's ionizing radiation, or X-rays because it's ionizing radiation, and because it is harmful, you have to be extra careful. 30% is believed to be unnecessary CTs. And definitely be careful in pregnancy. You will not subject a patient to radiation if the patient is pregnant or very small children, because of the various congenital, in pregnancy you can get birth defects, children you can get malignancies and all that. So you will not, unless very essential, subject pregnant women and children to radiation. So when you are reading an X-ray, these are some of the things that you will you'll look at to make sure. So obviously the name and the biodata of the patient, date, exact date, and the side of the X-ray, the view that is taken, and all must be checked. When you have only one patient in the day and you have taken an X-ray, probably this is not a problem. But in the X-ray department, when the radiologist examines a lot of X-rays, unless these details are carefully looked for, there is a chance of mixing up your diagnosis and findings between patients. Obviously, you must find out which is the part of the X-ray body which is being X-rayed. You must see in the film whether it has covered the whole area that you want. Like for example, when you take an X-ray of the abdomen, you need a very large film to take the to include the whole abdomen and the pelvis, whereas an X-ray of the skull requires only a comparatively smaller film. Children will probably require smaller films. Chest X-ray of a child will probably require a smaller film compared to the chest X-ray of an adult. So you must make sure that the X-ray is included all the areas that you want to see. Then when you take a look at the X-ray, you must see whether there are more than one view that has been taken. Like for example, chest X-ray, you can take a AP view, and along with that you can take a lateral view, because the lateral view will give you more details about certain things compared to just a simple PA or an AP view. So you must look at all the views. The quality of the X-ray film is again important, because depending upon various, like for example, if you're taking an X-ray for the ribs in the chest, the type of exposure penetration that you would give would be different for what you would want in the case of X-ray for the lungs. You understand? So that has to be checked. The other important thing is, when you are taking serial X-rays, you want to follow up a patient and you're taking a repeat X-ray, you must always see what are the changes that have taken place compared to the previous film. It might be better, it might be worse, or there might be something else that has appeared. All these things must be checked. And then, of course, one of the indications for taking an X-ray probably is to find out the diagnosis, isn't it? So you must obviously see whether your diagnosis has been confirmed or whether there's any change in the diagnosis. And it might give you a lot of extra details. You have a fracture, the X-ray will tell you not only whether there's a fracture, whether it's a comminuted fracture, all sorts of things. So, and finally, you must decide whether any further imaging is necessary or not. Yeah, this is a cautionary slide to tell you when you should not take an X-ray, or when you should not do any radiological examination. Understand? I think you can go through. So I'll just run through it. Results are unlikely to affect the patient. Obviously, there's no need. You know for sure that it is a fracture and it's a simple fracture and all that. Probably you will not need not take an X-ray even. But in a case of a fracture, you'd obviously always take an X-ray to have documented proof. That is another thing. So what I'm trying to say is nowadays we tend to over-investigate. So that is the caution here. Then sometimes you do an investigation where you are sure unlikely to get a positive finding. Again, that is unnecessary. Then probably irrelevant, you can take an X-ray where you get irrelevant findings. That is, so again that becomes unnecessary. So you can go through this whole list. So this is to tell you when not to take an do an investigation, especially investigation which is harmful to the patient, like X-ray, CT, PET and all, which are ionizing radiation and can cause problem for the patient. This slide shows you the responsibilities of the radiologist. Again, I'm not going to go into all the details. You can read it when you have time. One thing that I wanted to stress here is that an X-ray, patient undergoing an X-ray, the areas of the body which are especially vulnerable to the X-ray are the gonads, the eyes, and the thyroid. So unless you want to take an X-ray of these regions, they must, supposing you're taking a chest X-ray, you must protect these areas, the gonads, the eyes, and the thyroid of the patient before you take the chest X-ray. That is why they apply all those shields to the neck, to the eyes, and to the lower abdomen. That has to be, because these areas are very sensitive to radiation. Thyroid, the definite cause for thyroid malignancy is exposure to radiation. There are a lot of other risk factors, but this is a definite cause. So like that, gonads again, high cells which are dividing all the time, isn't it? Very high mitotic rate they have. So again, they are very sensitive to radiation. So that is why. Eyes again. Yeah, this is a comparison of the radiation dosage that you get with various types of X-rays and CT and all that. What you can look at here is probably, see, the background radiation is only about 2.2 millisieverts, and the maximum dose, that is the maximum radiation dose, industrial radiation dose that is allowed is around up to, I think, about 10 millisieverts. So there is not much of a margin. You have to be very careful about the dosage that you're giving. And as you can see here, plain X-rays have a much lesser radiation dose compared to uh, computer tomography. Yeah, so you can go through the slide and compare it for yourself. Yeah, this is a simple X-ray of the neck and this thing, showing our uh, coin and the esophagus here. Yeah, this is another chest X-ray showing you a pneumothorax. If you compare the right side to the left side, you find that this is completely black, whereas on the left side you can see these fine bronchovascular markings. That is the lung, normally expanded lung, whereas here the lung is collapsed here and only air is there in the thorax. That is why you get this whole completely black appearance. Yeah. This is another favorite X-ray of surgeons. This is showing you what is called gas under the diaphragm. This is the right diaphragm, dome of the right diaphragm. This is the dome of the left diaphragm, and you find gas between the diaphragm and the liver on the right side, and between the diaphragm and the stomach on the left side. This tells you that the patient has what is called a pneumoperitoneum. That is, there is gas in the peritoneal cavity, which is what you normally get when you have a perforation of the duodenum or the stomach or the colon and all that. Yeah, this is to show you, I mean, the difference between various the absorption of the X-rays by various organs. This is an abdomen, plain X-ray of the abdomen. See, you can see the bone looking all white. You can see the kidney shadow here. See, it is not as white as bone, nor is it as black as hair. Hair, hair outside black. So that is because the absorption of the X-ray varies between the bone and the soft tissue like the kidney. You can see the kidney on both sides. You can see the psoas shadow. See, psoas muscle shadow you can see very clearly. So you can see the air inside the intestine here. This is probably the transverse colon. You can see the air inside the intestine. So yeah, I don't know If you look very carefully, probably you can see this fat plane between the skin and the muscle here. See, fat plane. Air fluid level is not seen in this X-ray. Yeah, here you can see air fluid level. See, what position do you think this patient was in when the X-ray was taken? Obviously, the patient is in an erect position, either usually in a standing erect position. And then you take an X-ray. This is when what you do when you have a suspected intestinal obstruction. You find that there is an air fluid level here, which is normally present in most patients because this is the fundal area of the stomach. And obviously, the fundus always contains gas, isn't it? And it usually always contains some amount of fluid, either gastric juice or food which has been just recently ingested. And then when you make the patient stand up, that fluid forms a horizontal level, like fluid in any container produces a horizontal level, and then you get gas above that. So this is an air fluid level. This is a normal occurrence in normal people. But in intestinal obstruction, you tend to get multiple air fluid levels. That is how you diagnose intestinal obstruction. Yeah, this is an X-ray showing you, see, a calculus is mineral bone here. It's almost like bone. See, is as dense as almost as dense as the bone. This is probably a calculus in the gallbladder. It is not very common to get radio opaque calculi in the gallbladder, but in this particular case, it seems to be in the gallbladder. The other possibilities that is it is in the kidney. I think. Sorry. Yeah. Yeah. For this, you'll have to take a lateral view. That is why you often require multiple views. X-rays, you require multiple views. So a lateral view will tell you whether it's a gallbladder calculus or a kidney calculus, because a gallbladder calculus will be anterior to the spine in the lateral view, whereas a kidney calculus will be at the level of the spine in a lateral view. Yeah, this is a mammogram showing you areas of yeah, you can see the lesion here. Yeah, lesion here. Yeah. Mammogram again is an X-ray. Only thing is the dosage is less compared to the conventional X-ray. Yeah, that is the difference between it's an X-ray actually. There is no only thing is it's limited to the breast, and the dosage is much less. Yeah. So we were so far discussing plain X-rays. A mammogram is also a plain X-ray. All right. Now we come to contrast X-rays. What do we mean by contrast X-rays? Contrast X-rays helps to delineate something. You get a contrast between something which is there in a cavity and something which is not there outside the cavity. So you get that contrast between the two. So it helps you to see a lot of things. The initially what we used to have is barium, which was used as a contrast. Now this barium can be either given orally, in which case you can get a barium swallow, which will help to show you the esophagus. You can get a barium meal, which will help to show you the stomach. You can get a barium meal follow through, which will help to show you the small intestine. From the other end, you can do a barium enema, which will help to show you the rectum and the colon. So this is how barium can be given. Contrast media can also be given intravenously. That is how we do a intravenous urogram, IVU, where you give contrast medium through the vein and it's excreted by the kidneys. So that helps to delineate the kidneys. The contrast, when it's being excreted by the kidney, helps to delineate the kidney. Then it comes into the collecting system. So you can see the pelvis, you can see the ureter, you can see the bladder. You can do a micturating cystourethrogram, where during micturation you take a film to see whether there is an obstruction to the flow of urine. So that is one example. You also use intravenous contrast media for doing contrast enhanced CTs. CECT, contrast enhanced computer tomography, is also done using intravenous contrast media. You can inject it directly into the arteries. Contrast media can be injected directly. The thing about this is these are all usually iodinated compounds. This is what I have shown you here. So iodine. So, and they are usually, you get two types. You get fat soluble and water soluble. Nowadays we tend to use more water soluble, or yeah, low density contrast media. Uh, yeah, you can inject it directly into the arterial tree to see whether there is a say, for example, an aneurysm or angiodysplasia somewhere. So you can, so wherever there is an orifice, you can inject a dye and take away. You can do a bronchogram, you can do a ERCP, you can do that where you can delineate the whole biliary tree. IVU I already told you about. Like that you can see almost any part of the body nowadays using a, you can inject into the vein to do a venogram. You can inject it into the lymphatic system to get a lymphatic lymphangiogram. So all these things can be done. Yeah, this is a barium swallow showing you the esophagus, and as you can see here, this is normal looking esophagus. As you come down here, there is a irregular filling defect, which is probably suggestive of a malignancy. So as I told you, it helps to show you the contrast between the barium within the lumen of the GI tract and the surrounding area. You understand? That is what we mean by contrast. Again, barium swallow. This is showing you a smooth filling defect. The previous one I told you is an irregular filling defect. Here there is a smooth filling defect at the lower end of the esophagus. This is an achalasia cardia. And don't worry about the diseases. You understand the principle involved here. Understand? Yeah, this is a barium meal follow through. That is, this is a small bowel that is seen. The previous one we saw the esophagus. The barium meal follow through. If you look carefully, you can see the Ryle's tube in the stomach. Yeah, this is a barium enema. The other one I told you is all taken orally. This is given through the anal canal. This is a barium enema picture. Yeah, this is spot films taken of the barium enema showing you a lesion here. Yeah, this is again a barium enema. As you can see, this is the normal colon. This area is contracted. There is irregular mucosa seen here. Sorry, and here you can see there is a filling defect. It's not going beyond that. You understand? So that is either probably an interception is what I think this is. Yeah. The other thing is when you are looking at an imaging study, you must definitely find out what the history and physical findings were, because just looking at the X-ray or the CT, you may not always be able to say for sure what it is. You need the history of the patient and the physical findings. You have to correlate the two. Only then can you give a different diagnosis. Yeah, I told you we use iodinated compounds for doing all sorts of intravenous studies, not only intravenous studies but all sorts of contrast studies. The problems with this contrast media is, one, you can get allergic reactions. The incidence about 1 in 2,500 people can get. Life-threatening allergies can take place in 1 in 25,000 people. So you have to be careful when you use contrast media. We use low osmolality contrast media, that is between 5 to 10%. It lowers the risk of the problem. Yeah, this is how to avoid allergic reactions. You understand? You use low density osmolality contrast media. You can give steroid prophylaxis, and then after giving the contrast, you must definitely observe the patient for about 30 minutes to make sure that they are not developing any allergic reactions. So these are the ways of preventing allergic reactions. The other problem that you can major problem that you have with contrast media is they can develop nephrotoxicity. So you will find before we IV contrast, I'm talking about IV contrast, you can give barium meal, there's no problem. But when you're using IV contrast, you will always check the function of the kidneys before you give it. So that is why you will find that in the form itself, you will find a column asking you for the serum creatinine value of the patient. So you will always do a serum creatinine before you give IV contrast in, for example, when you are doing CECT, things like that. So if the patient has renal failure, you will not use IV contrast. Now, how will you provide how will you prevent nephrotoxicity? Obviously, you must check the renal function before the study. Then you will maintain good hydration, and again you will use low osmolality contrast media, and you can give an acetylcysteine, which helps to protect the kidney from the toxicity of the contrast media. Sorry. Yeah. Patients who are diabetic or who are on metformin can develop lactic acidosis. So so in a patient who is diabetic, you must definitely ask for the drugs, and if the patient is on metformin, you must be careful to give only small quantities of contrast. That is 10 ml, 100 ml or less of contrast to prevent lactic diabetes, as it is have a tendency to develop acidosis, isn't it? Ketoacidosis. On top of that, you get you will worsen it by giving contrast. So you must be very careful. Gadolinium is a contrast which is used in MRI studies, that is magnetic resonance imaging studies. The contrast that is used is gadolinium. You don't use iodine. Iodine is used in CT studies and various other things. Now, gadolinium also can produce allergic reactions, and they are also nephrotoxic. The other life-threatening complication that you can get with gadolinium is nephrogenic cystic fibrosis, which is almost irreversible. So you have to be extremely careful when you use this particular contrast media. Yeah. Contraindications to using gadolinium would be severe renal failure, neonates, pregnancy, and perioperative patients after liver transplant. After perioperative, you will not use gadolinium. Yeah. This is an intravenous pyelogram. You can see kidney and the kidney here. Outline of the kidney can be seen. Now, see, when you do an intravenous pyelogram, you take, first of all, you take what is called a scout film. That is without giving the contrast. Then you give the contrast, you take a film immediately. Then after 5 minutes, after 10 minutes, like that, you keep on taking films at various time intervals. So the initial films will show you the outline of the kidney. It's called a nephrogram. It will show you the kidney. See. Then after a little later, you get the collecting system. That is the pelvis. Then the ureter gradually. Then you will find the bladder filling up with the dye. This is a tube cholangiogram. This is the biliary tree. This is the common bile duct, as you can see. This is the right and the left hepatic ducts, and then the other branches. This is a tube cholangiogram because see, you can see what is called a T tube. This is what is usually put in after exploring the common bile duct. When you do surgery on the common bile duct, when you are closing it, you usually put in a T tube so that in case the patient develops some obstruction to the biliary tract, because of either stricture or a retained stone, things like that, the bile can drain out through this and the patient will not develop obstructive jaundice. Post-operatively, you want to check whether there is any obstruction to the biliary tract. You can inject dye through the T tube and take a film. This is what. So I told you, you can use this iodinated contrast media for a lot of studies. This is one example of that. The previous one we saw was the urinary system. This is the biliary system. It's similarly when you do an ERCP, that is endoscopic retrograde cholangiopancreatogram. What you do is you pass an endoscope through the oral cavity, through the stomach into the duodenum. You cannulate the papilla vater and you inject dye and you will get a similar film. Instead of it coming through this, it will go like this through this. You can also get a pancreatogram, that is, you can get a film of the pancreatic ductal system also along with it. Yeah, this is an angiogram. Obviously, this is the knee joint, isn't it? And as you can see here, you can see the femoral artery is fairly well delineated, but beyond that, you don't get the tibial or the peroneal vessels absent. But distal to that, you get the vessel again. So this is what is called the distal runoff. But though the tibial vessels and the peroneal vessels are not seen, you can see the collateral vessels here. See, collateral vessels here. So these are various, so you can see the site of the obstruction, you can see at what length the obstruction is, you can see whether there is a good distal runoff, whether there is a presence of any collateral vessels or not. All these things can be seen in angiogram in arterial obstruction. Yeah. This is a portal venogram. This is the portal vein actually. So this is what is done when you have portal obstruction, portal hypertension, and you want to see the portal vein. You can inject it through the spleen. Yeah. So this is the portal hypertension showing you dilated portal vein. So what I'm trying to tell you is you can inject it into all sorts of areas to visualize things. contrast media can be injected into all sorts of areas to visualize things. Yeah. Then we come to ultrasound. Ultrasound luckily does not contain ionizing radiation. It has radiation but it's sound waves, and so it is comparatively safe. It is in fact very safe compared to X-rays and CTs and all that. So you can do it on pregnant women, you can do it on children, you can do it on any type of people without causing any harm. That is the important thing one important thing to remember about ultrasound. So this is the advantage of ultrasound compared to radiation. There is no radiation. It is comparatively inexpensive. It allows interaction with the patient. What I mean by that is the person who is doing the ultrasound sits next to the patient and does the scan. So you can talk to the patient, find out is there pain here, is there no pain there, things like that. You understand? Whereas when you're doing a CT, the patient is in one room, you're in another room, or when you're taking X-ray, also the patient is in one. You cannot interact with the patient. That's the thing. So, like, or for example, the patient has a tendon injury, say for the tendon Achilles. You can ask the patient to move the foot so that you can see whether there is a widening of the defect. So you can interact with the patient. Very important sometimes. Yeah. The other advantage of an ultrasound is it gives you superb soft tissue resolution, unlike an X-ray. Uh, and you can do dynamic studies. Again, what I mean by dynamic studies, the example I gave you previously. Supposing you have a tear of the tendon HLS, you do an ultrasound, you find that there is a tear. You want to confirm the tear, you can ask the patient to dorsiflex the foot. Then what will happen? The gap in the tendon HLS will widen, and you can make out that on the ultrasound. So you can. This can also be done using an MRI, but it's a little more cumbersome, whereas this is much more easier to do. Yeah, and nowadays we use this as a first line investigation in hepatic, biliary, and renal diseases. Gallstones, when you suspect gallstones, cholelithiasis, ultrasound is the first investigation that you do. Similarly, when you suspect, say, a cyst in the liver or a tumor in the liver, an ultrasound is the first thing that you'll order. Similarly, renal calculi, first thing probably that you'll order is an ultrasound because it contains a lot of fluid. That's the thing. So, which gives you good pictures. Ultrasound does not go through gas. It goes through gas, but it does not reflect it. So you will not be able to get a picture. Whereas liquids are good conductors, so you get good pictures when you have liquid surrounding the lesion that you want to see. Yeah, you can use endocavitary ultrasound for gynecology. You can use it. You can use it for assessing the prostate. Endoscopic ultrasound can be used to assess the T stage of rectal cancers. It can be used to assess the T stage of esophageal cancers, which is not possible with other types of imaging, not as accurately possible with other types of imaging. So a lot of things, and can be you can have small, you have small probes. You can use a probe in the oral cavity, like that. You can use a probe in wherever there is an orifice. You can probably put in a probe and use it to get better pictures. Yeah, it gives excellent resolution. It has excellent breast, thyroid, and testis and all that. Testis, for example, you are suspecting a torsion of the testis. You want to do find out whether there's a torsion or not. Other than exploring the thing, the best and probably the only other investigation that you can do is a Doppler study, ultrasound along with a Doppler study to see whether the vascularity is normal or not. So that a lot of things. Yeah. Ultrasound is a good investigating modality for soft tissues. Tendon, I already gave you an example of the tendon HLS, tendons, ligaments, and all that. And I told you you can use do a dynamic study. An X-ray, you can do it, but you'll have to keep repeating the X-ray, and yeah. And you cannot see tendons with that with an X-ray, isn't it? Only bone can be seen. So that's the problem. The other thing that I must emphasize here is I told you it gives excellent results when there is a lot of water in the tissue. So it's excellent for diagnosing cysts. So if you have a suspected, you want to know whether a lesion is a cyst or a solid tumor, an ultrasound is probably the best modality. Problem is you cannot use it when there is a lot of depth, when the tissue is at a great depth. Yeah. The other thing is ultrasound can be used to diagnose foreign bodies. In the olden days when we had X-rays, we used to use X-rays, but the problem is X-rays cannot pick up foreign bodies, like for example, other than dense foreign bodies, like metals it can pick up, bone it can pick up, all right. But supposing there is a plant, you splinter of wood is there in the body, you will not be able to pick that up on an X-ray. You will, whereas an ultrasound will be able to pick it up. I told you nails, thorns. I mean, not thorns, nails, things like that. That is, metallic objects can be picked up on an X-ray, but an ultrasound can also pick up non-metallic objects. So, like I gave you the example, probably would be a splinter of wood. You suspect a patient hand injury from while he was doing something on a wooden piece. There is a splinter. You can pick it up on an ultrasound, which may not be picked up on an X-ray. So that is the other advantage of ultrasounds. Ultrasounds are also useful in doing Doppler studies. Doppler studies are flow. It shows the flow of blood within the vessel. You understand? So it can be used to do Doppler study. Doppler study, you can use it in studying the limbs for varicose veins. You can use it for studying the limbs for arterial flow. I already showed you a picture of an arteriogram. That is, you have to inject a dye into the artery to see that. Whereas in ultrasound, without using a dye, you can make out almost all those similar findings. So it avoids the use of a dye and all the complications associated with that. And it can be used as a screening study also, probably. Yeah. I already told you one of the uses of imaging is to do guided biopsies. Ultrasound is probably the easiest way of guiding a needle into a tissue. So whether you want to take a biopsy or whether you want to drain it, you can use an ultrasound to guide your needle or the drainage tube to the correct location. The problems with an ultrasound is it is highly operator dependent. That is to say, the person who's doing the ultrasound has to be good. It is not possible for everybody to go and do an ultrasound and pick up things. So you have to be specially trained in that, and the learning curve for this is quite high in certain areas. So it requires a lot of expertise. Then the pictures that you get or the resolution that you get is dependent upon the machine that you use. There are various machines that can be that are available. So if you get a high-end machine, you will be able to do a lot of studies with much more reliable data that you get from it. Similarly, there are various types of probes. I told you you can use a probe for the oral cavity, for the rectum, for the vagina, like that. So endoscopic this thing, esophagus, you have probes. So the probes also vary, so you require all that equipment is necessary. Yeah. The thing is, the ultrasound can be seen only when you're next to the machine. They do give you pictures of the ultrasound, but that is a static image which is not very useful unless it is a calculus and all something like that. For other, like for example, tendon injury and all that is much better viewed at the side of the machine. You cannot, unlike an X-ray film. An X-ray film you can carry it from here to America and still look at the X-ray film. It will be the same here or in America. But when you're doing an ultrasound, you have to do it here and you have to see it here. You can't record the same. I mean, you cannot get the same finding when you cannot review this finding in America. And nowadays, probably with the newer gadgets and all that, probably you can do it. But the olden days that is not possible. So what I'm trying to say is that it is very operator dependent, and you cannot repeat the thing exactly the same area, the same this thing always. Unlike an X-ray, you can repeat a chest X-ray any number of times and it will always be the chest without. Whereas this, you take a say for a tendon injury, it will keep on changing depending upon slight variations in the angle in which you have kept the probe and all that. So yeah, the normal range of ultrasound waves are 2 to 18 megahertz. The lower the higher the frequency, the more the penetration, but the poorer the quality of the picture. Lower the frequency, the less the penetration. That is just under the skin and all that you can see with low frequencies, and you get very good images. But high frequencies used for deeper structures, but the images may not be resolution. What I mean by images, the resolution may not be that good. Yeah. Yeah, this is a ultrasound of the abdomen to show you the thickened endometrial layer seen in the secretory phase of the menstrual cycle. Yeah, this is showing you a metastasis in the liver in a patient with colorectal cancer. Yeah, this see, this is showing you the tendon. You can see the fibrillar pattern here. See, tendon, beautifully seen. Yeah, this is muscle fibers. You understand? Just like a feather. Typically, this is how the muscle fibers are arranged, isn't it? Lamina, yeah, beautifully seen again. All these ultrasound pictures, remember? Yeah, this is a Doppler ultrasound. Ultrasound, see, showing you the blood flow through the vessel. Now, interpreting this and all you will learn later, but basically it depends upon the flow of Doppler effect. You all heard of the Doppler effect. Train passing through, you get that sound varies from as it is approaching, then it reaches you, and as it leaves, that change. So the RBCs within the blood as it is flowing reflects the ultrasound and gives that Doppler effect, so which is picked up by the computer and gives you a graphic picture. Gives, yeah, showing you nodularity in the liver. Yeah, this is again and ascites. This is a Doppler study on this. You can see ascites here, black liver, chest wall, ascites. It has multiple nodules which are not very. Like, yeah, there is one. Yeah, this is a Doppler study in portal hypertension. I mean, we won't go into too many details here. Yeah, so that covers the advantages and disadvantages of ultrasound. Now we come to computer tomography. The advantage of computer tomography is it gives high spatial and contrast resolution. Uh, and you can enhance this contrast resolution by taking films in the arterial phase and the venous phase. After you inject contrast media, you take it in the arterial phase and the venous phase. It has to go into the artery and then go into the vein, isn't it? So you can, depending upon the time lag, you take it in the arterial phase and the venous phase. And you can the advantage of CT compared to magnetic resonance is that you can get new, multiple films when you just hold the breath once, whereas an MRI takes a longer time to get a film. That's why the MRI scanning takes longer time compared to a CT scanning. Now the present CT scan machines that we use do it much faster. Yeah, pulmonary masses are best seen by CT scan. You cannot visualize the lung using the ultrasound because it is full of air, and I told you it does not reflect the ultrasound. So you cannot. So you can. The other thing about ultrasound, disadvantage about ultrasound, you cannot use it to visualize areas which contain air. It cannot pass through bone. So the pelvis, if you want to do an ultrasound of the pelvis, you cannot do it because it will not pass through the bone. In the case of air, it will not reflect the ultrasound, so you cannot image it. Understand? So the lung, you can probably look at the wall of the chest, thoracic wall, but you can not see the lung. And so structures inside the lung also cannot be seen on an ultrasound. But all these can be beautifully seen on a CT scan. Yeah, CT. It helps you take a CT scan of the abdomen and pelvis. You can see all the structures in the abdomen and the pelvis. Again, solid organs, liver, pancreas, renal, and all this, or GI tract can all be beautifully seen by CT scan. The bowel, again, because it contains a lot of air, cannot be seen well on an ultrasound, but solid organs can be seen on an ultrasound. That is, solid liver, pancreas, kidneys, and all can be seen on ultrasound. The modern CT machines can give you a three-dimensional reconstruction of the film, which will help you to localize the lesion, help you in taking guided biopsies and all that. Then you can have multi-planar reconstruction. So angiography, just like a movie, you can see the dye passing through the veins of the artery and all that. Yeah, the problems with the drawbacks with a CT is it is very high. You get a very high dose of radiation, and soft tissue resolution in the periphery and the superficial structures is poor. Yeah, patient has to lie down flat. So the patient is not able to lie down flat is a problem. Yeah, this is the CT machine, and this is what is called the CT machine. This is what is called the gantry. The patient lies on this, and you can see the table-like thing. The table keeps moving through the CT machine, and the X-ray. You get X-rays all around this. You understand? Or there is a single X-ray machine which keeps on rotating like this, and multiple X-ray. A CT is also a X-ray. All right. Only thing is it goes all around. Instead of an X-ray which takes only one plane like this goes all around. So you get three-dimensional views. And depending upon the slice, you get that depends. The thickness of the CT film depends upon the machine. You understand? This is the CT of the head showing you a large lesion here. Again, because there is a lot of bone, ultrasound cannot be used for the skull. I mean, cannot, yeah, skull and the brain. You have to use a CT. CT shows you this. An X-ray will show you the bone, but it will not show you all this. Similarly, an MRI, I mean, MRI is a good investigation for the brain. Yeah, this is again pelvis. Pelvis is bowel. This is bowel. Pelvis, sacrum, bowel. Yeah. Magnetic resonance imaging again. I think we don't have too much of time, so I won't. Yeah, the relative advantages and disadvantages are all given here. You can go through them. The main thing I want to stress here is that magnetic resonance imaging does not contain ionizing radiation. So you can use this in situations where you cannot use a CT. For example, in pregnant women, small children, and you can use it repeatedly without causing any harm to the patient. Whereas a CT, I told you, you cannot use it repeatedly because of the ionizing radiation. There is a maximum dose that the body can bear. Beyond that, you cannot go. Whereas magnetic resonance imaging, you can keep repeating it at will. Yeah. The disadvantages are that bony lesions are much better seen on a CT compared to a magnetic, but soft tissues are much better seen on a MRI, magnetic resonance imaging. The other things you can go through it and see. The other disadvantage of magnetic resonance imaging is the patient has to go through this machine, understand, and it takes a much longer time, almost half an hour to 45 minutes, depending upon the type of study and all that, compared to a CT, which you can finish in 5 to 10 minutes. So the patient tends to develop claustrophobia, and small children and all may not lie down quietly on the gantry, so you might have to give them sedation. That is one other. The other thing is because it is magnet, obviously the patient must not have any metallic objects in the body. So you cannot use it when the patient is on a pacer, cardiac pacer and things like that. And in the olden days, we used to have metallic, these things for fractures. We used to use metallic structures for correcting fractures. So you must make sure that, and the patient should not be wearing any metallic objects because of a very high part magnet and can cause all sorts of problems. So that is one very important thing that you must make sure of before you subject a patient to MRI. Yeah, there's an MRI. Now there is T2 weighted, T1 weighted and all. I won't go into the details. It helps to differentiate between various things. MRI of the brain. Yeah, there's an MRI of the spine showing you an vertebral disc prolapse. So nicely seen here. Contrast has been injected. Yeah. Abdominal aorta. See. MRI nowadays is used for a lot of things. It can be used for doing an ERCP instead of an ERCP, you can MRCP to delineate the biliary tract. You can use it for the arterial system. Pancreas, you can use it for the pancreas. Even the coronary arteries now can be imaged using MRI. So you do not require any invasive procedure. Normally when you do a coronary angiogram or when you do an ERCP, you have to put in something into the oral cavity. In the case of ERCP, you have to put in a tube into the oral cavity, into the duodenum and all that. Or when you do a coronary angiogram, you have to put in a catheter into the coronary vessels. Whereas when you do an MRCP coronary angiogram or an MRI coronary angiogram or an MRCP, that is, there is no need for all these invasive techniques. Yeah, this is a cholangiopancreatogram. I told you. Without, yeah, then coming to radionuclide imaging. Again, radionuclide imaging uses radioactive substances. So again, it is ionizing radiation. The other thing about this is it gives you good idea about the function, but it does not give you spatial resolution. So you'll not be able to see the structure as clearly as you get it in a CT or an MRI, but it will give you a good idea of the function of that particular. So that is why we keep doing radioactive iodine scans in the case of the thyroid, because the thyroid is a very iodine avid structure. You give radioactive iodine and you use a radioactive camera, you can picture the thyroid and it will tell you the amount of the radioactive iodine that is being taken up by the thyroid. So it will tell you whether it is hyperactive, that is whether it's taking up too much of iodine or less of iodine, and it will tell you the areas in the thyroid which are taking up the more iodine. But it does not give you such a good spatial picture. That is, the outline may not be that clear, but it will tell you that this particular spot is taking up too much. Sorry. uh, so that is the thing. Yeah. I think I won't go into too many, too many details about it. So that is the thing. That is a big difference between CT scan, magnetic resonance imaging, and nuclear scans. So nuclear scans, again, depending upon the type of function of that particular body, you can use specific. I told you radioactive iodine is almost specific for thyroid, because the thyroid is what takes up iodine most. There are certain other areas which take up iodine, but it does not take up as much of iodine as the thyroid. Similarly, the parathyroids can be seen with using sestamine, which is it again, sestamine is taken up by the salivary glands and all that. But if there is a hyper functioning area in the parathyroids, it retains this sestamine much longer than the other areas. So you can see that. Yeah, this is a camera that is used to for nuclear studies. Yeah, this is a whole body bone scintigraphy. See, you can see metastatic lesions all over the skeletal system. Metastatic lesions. This is called a, yeah, this is a thyroid scan being done after giving radioactive iodine. Yeah, this is what is PET scan. Sorry, this thing used for PET scan. This looks just like a CT scan or an MRI appearance wise. PET scan. The PET scan, the principle of a PET scan is you give what is called FDG, 5-fluorodeoxyglucose, which glucose is obviously taken up by cells which are in the which are used it for metabolism, isn't it? So malignant cells or inflammatory cells are usually much more metabolically active than normal cells, so it takes up more glucose, and you, by giving this radioactive glucose, you can pick it up using a PET scan to see which areas are taking up more glucose. So that will tell you that there is increased function there. So if it is a so you can make out that increased function, and if it is a malignancy, it will tell you that there are metastasis, deposits in various other parts of the body. So that is the advantage of doing a PET scan. Yeah, this is to show you the mechanism by which you the PET scan, the principle on which the PET scan works. I think I've run out of time, so I won't go into too many details. Yeah, now depending upon the area that you want to scan and the type of lesion that you want to scan, you will pick a certain type of imaging. So in the case of the bone, probably an X-ray is the first type, is the imaging of choice, initial imaging of choice. Whereas the magnetic resonance imaging would be good for bone marrow, occult fractures, tendon and soft tissue disorders. CT is much better for finer details of the bone. So CT is also very good if the plain X-rays are not giving you sufficient information. The next go-to investigation would be a CT. Ultrasound is good for soft tissues, and I told you it can be used dynamically, which is very important. Yeah, and I told you again, it is useful where X-ray is not X-ray will not pick up tissue foreign bodies. You can use a ultrasound, and an ultrasound is very good in differentiating a solid from a cystic lesion. That is one of the greatest advantages of an ultrasound. Even a CT may not be able to give you a good idea sometimes. This is what I was telling you. It can detect non-metallic foreign bodies. Muscle hernias, probably an ultrasound is the best. The specific types of imaging, I think we'll leave for some other time since we have run out of time. Yeah, this is to give you an overall picture of various imaging techniques that are available. It is not possible to cover each technique and each area of specifically, which you will learn as you go through each system.